Good morning. Welcome to Whistler. Welcome to our course. Nice to see so many faces that I recognize. Some of you I don't recognize. How many of you have not taken a version of this course in the past? Oh, wow. Where have you been? You know. Okay. Where are the Australians? There's usually a section. You're spread all over. We usually have a group of you in one row, but today all over. Canadians, where are the Canadians? A lot of Canadians, okay. There's more Australians, I think, than Canadians. Sign of the times. My name is Rick Bukata. I'd like to welcome you to our course. This is the first course of our 28th season doing this stuff. Your manual basically is the same every year. We have the abstracts from our emergency medical abstracts. We pick up the articles that we think that we want to review on 32 narrow topics. This is our third year of doing this way, so we've done up to 96 topics. The goal is the new, the controversial, the leading edge. We hopefully we're not going to be covering stuff that people, oh yeah, everybody knows that kind of thing. So, and we're also inviting you to participate. Those of you, the best courses we do are the ones when you feel comfortable to interjecting, and this is the way we do it, and no, we don't have much luck with that kind of thing, and no, I don't disagree, those kinds of things. So feel comfortable. And we're also, we've scheduled the day so that, you come in at 7:30 and you get out at 9:30, you go back to your room, you study the manual for 5 hours, you come back in the afternoon, and then you go another couple hours. That's then how this works. Anything else that we need to talk about before we get started? Anything anybody wants to say here? Speak now? Okay, let's begin then. We're going to do aortic dissection first. Was that aortic dissection? And the reason we're going to do aortic dissection is because I'm from Los Angeles, and 2 years ago, there was a very famous case of somebody who had aortic dissection. Anybody want to remember who that was? John Ritter. And Burbank Studios is right across the street from St. Joseph Hospital in Burbank. And he was doing a show there, and he didn't feel so good, and he told his friend, Arthur Fonzarella, remember Fonz, that he wasn't feeling so good, but he kind of was getting a little lightheaded and clammy, and they took him over to the ER over there, and within about an hour he was dead of a dissection. And there was a big lawsuit down there, made the LA Times pretty frequently as they followed this case through. And the hospital settled for $13 million, and one cardiologist and one emergency physician was named in the lawsuit, and ultimately they got off. Because his case was so atypical. Why the hospital settled, one of the reasons was that they ordered a chest x-ray, and it never happened to get done kind of thing, and so that happened there. California is kind of interesting. We have a lot of lawsuits there, and a lot less now that we have this cap on pain and suffering. So a cap on pain and suffering was only $250,000 cap on pain and suffering, and yet they were going for all of his potential lost wages, and that what made the lawsuit really very provocative. Big numbers are being thrown around. So that basically is part of the big three that somebody comes in. I got something going on in my chest, and the big three are pulmonary embolism, acute coronary syndrome, and aortic dissection. And statistically, by far, the least common is going to be aortic dissection. When you look up the ratio of ACS to aortic dissections, some people say it's like 1 in 400. How many of you have seen an aortic dissection? Wow, so everybody basically has had your opportunity, but how many have seen more than 2 or 3? Okay, what is it? Is that the Australian section they're answering there? Okay, But the fact of the matter is they're certainly rare, and yet it's one of the things we're not supposed to miss. You're not given a second chance on this kind of thing. And hopefully the presentation will not be like John Ritter's, but will be the more classical presentations. The first question that this book asks, and our premise and our process here is to ask some questions, see what the literature says. Ask some questions, see what the literature says. What's the role of exertion in exciting aortic dissection? Well, we know that MIs are associated with exertion. People shoveling snow and those kinds of things get MI. There is a clear relationship between getting your blood pressure high and maybe having your heart basically needing more oxygen than you're able to provide. So two of my friends, basically, one of my friends had his MI on the Treadmaster, Stairmaster. You know, stay away from that thing, you know. It's trouble, man. And the other one, this is oddly enough, had his MI carrying a resuscitanti to a CPR course. So this is an older doctor. Those things weigh up a ton. You're going up the steps with the resuscitanti. He got chest pain, and that's when he had his MI. That wasn't good. Which brings up the story of we were at the Fairmont Hotel this is a Fairmont Hotel. We were at the Fairmont Hotel in San Francisco many years ago, and they were doing a CPR course, with the pressing and the shocking, and everybody was getting ACLS certified kind of thing, AHA, and it was a big course. And somebody had the nerve to drop dead in the lobby of the Fairmont Hotel. So they had all of this equipment, all of these doctors. They go down, take care of this sucker didn't have a chance. This guy died so badly, you know, with all of this equipment and all of these doctors around. But in any case, this paper here, this first paper talks about, yes, strenuous activities associated with people who can recall what they had during the setting of their dissection. Yes, a quarter of them said, yes, I was doing something strenuous kind of thing. They're talking about all kinds of stuff. They always list in this thing vigorous sexual activity. You know, I always wonder, what the heck are we talking about? Did we get the trapeze up or something like that? You know, what's going on here? But anyway, that's part of the list, a quarter of them. So the same question you would ask and a precipitant of ACS is a precipitant of dissection. The same thing is true of stress. 40% of them said, yes, I can tell you a stressful event that precipitated this. I get some bad news, I lost my job, finances, those kinds of things were a precipitant. So the same questions that you would ask ACS apply here as well. One of the things that this paper said that was kind of interesting is these people are young, relatively speaking. When you look at the age of these people, 58, 60, 61 kind of thing, these are not 70, 80, 90-year-old people kind of thing having these things. They're basically around 60 years old. There are cases in here where they talk about 18 and 19-year-olders having a dissection because, in fact, there is this genetic predisposition, which is going to be coming up on the second question, does aortic dissection tend to run in families? This paper says, yes, this is an autosomal dominant kind of thing. And so they talk about a 19-year-old who had a dissection. 20% of patients will report the same condition in a first-degree relative. That's kind of a really high number. So if you ask somebody, has anybody in your family ever had some kind of aortic problem, you're going to get an answer, yes, substantially in these cases. Because of this relationship. Now, they don't necessarily have to look like Abraham Lincoln either to have this genetic relationship. Somebody comes in wearing a stovepipe hat, you know, with chest pain, I would get a little nervous, but the fact is, there is this relationship genetically, and it would be interesting for you to put that into your armamentarium, because what we're trying to do here is we're trying to create a chart that makes it clear that you've considered this diagnosis in every soul that comes to your place with chest pain. You have to make it clear that you've considered this, and whether you put down things which are in fact truly makes it clear that this is not or is dissection is another matter. Now you're working your shift and this person comes in and they've got something going on, but they don't have any chest pain, and maybe they're having some neurological kinds of symptoms. This issue of dissection without pain is absolutely bad luck when you're working, because this can occur. Does it occur very frequently? They say 5 to 10% of the cases. So we're talking about a rare condition, a small percentage of a rare condition having no chest pain with association with an aortic dissection. There it goes, John Ritter. A setup for problems. And in these cases, they must come in with something wrong with them, no chest pain, they're coming to be seen. Many of them have neurologic symptoms. And when they talk about the neurologic symptoms associated with aortic dissection, they list every possible thing that you can think of, from strokes to spinal cord dysfunction to peripheral nerve dysfunction, the things that it may be transient, it may be anatomically inconsistent, it doesn't look like a middle cerebral artery, it's got a little this, a little this. So they talk about basically a weird constellation of neurologic symptoms. Some might be very obvious, some might be very slight, that may come and go. without the setting of chest pain. And the first thing you're going to do in those cases is get the CAT scan of the head. The CAT scan is normal. Here's your thrombolytic therapy. Goodbye, John Ritter. That's the risk. The risk is basically you will think that this may be some kind of atypical stroke. The CAT scan will be normal, allowing you to give the thrombolytic therapy, which will be basically kill these people. So they say in this setting, neurologic findings, maybe you should consider this diagnosis, aortic dissection. Certainly would be uncommon. Yes, let's look for some of the other things that may go along. So the classic findings are, maybe they talk about unequal carotid pulses, unequal peripheral pulses. They talk about, taking a chest x-ray, looking for the mediastinal widening, hearing aortic regurgitant murmur. They say that comes up 20% of the time. Why? Because these things usually start at where the heart and the aorta come together and they go up, the aortic arch kind of thing. That's a type A, the Bakey kind of thing. That's the one that is most associated with neurologic conditions. So you're looking in the chest x-ray. Hopefully you're going to find something that doesn't look right. We'll talk about chest x-rays in a bit. They talk about left pleural fusions. Those are, you're going to be pretty far down the road when you see this. But all of these things are being put into your chart to make it clear to when the review is being done for the missed aortic dissection case. This doctor obviously thought of this. You looked for all of the things that we traditionally associated with this, and unfortunately, either they weren't there or they got missed. But the fact of the matter is that this doctor tried. He was not, or she was not negligent, and these things happen. So they say neurologic symptoms, 20 to 40% of cases, a huge percentage of these cases. Most of them, fortunately, will have chest pain. So they have chest pain and a neurologic symptoms. Basically, that's considered an aortic dissection until proven otherwise. About a third of these cases have no chest pain. Their only presentation is going to be some weird neurologic symptoms as a result of this dissection, blocking off some of these, the roots of some of these blood vessels going to the spine, the head, the neck, those kinds of things, which is a problem. This paper that I'm talking about here also notes 58-year-old median age for these cases, and cases as low as 18. So you've all seen heart attacks that are, young age. This disorder is typically viewed as a degenerative disorder, certainly not going to be in young people. This basically, paper after paper after paper says, no, you can have it in a 20-year-old person coming to you. Any of you ever give a TPA to an aortic dissection patient? Now look at all the hands going up there. Not that you would admit that. Congratulations. Is that Peter in the back there? It's a therapeutic kind of thing, How reliable are the classic findings? This is the thing that basically, you're going to put this stuff down in the book, in the chart that you've looked for it, but the fact of the matter is that classical findings may be present in the minority of cases. So number 5 is a review, a 21-article review of 2,080 dissections. How do you get 2,080 dissections? This is like a turkey ranch or something like that. Turkeys are predisposed to aortic dissection. Did you know that? Turkeys are? Yeah, they are. Well, turkeys and pregnant women are predisposed to aortic dissections as well. Anybody else predisposed? Well, obviously, the few Marfan patients that are, become president. But there are these small subset. So in any case, they looked at classic presentations. Classic presentations, less than half of the cases were classic. So you're going to do your best to put down what you think is expected of you, but don't necessarily count on it. And the key here is combinations. Yeah, you may not find unequal pulses, but you have some suspicion on the chest X-ray. This is going on, that's going on. So the idea in all of these situations, and we'll talk about it a little bit more on some of the other things, is this idea of your thought process, coming up with connecting the dots between these findings and saying, okay, I think this is a reasonable likelihood. They also talk in number 6 about, the big three. The big 3, aortic pain, immediate, severe, tearing, ripping, odds ratio is 6 times more likely if you have that. Mediastinal widening on a chest x-ray, odds ratio for that is 58, huge. If you see it, the question is whether you see it. And then lastly, differential pulses. odds ratio for that, 10 times more likely that that's the diagnosis if you find differential in the pulses. But this paper, number 6, says 7% of the patients who have aortic dissections had none of those findings. None of them, 0 out of 7%. So you have to be willing to acknowledge that there is a lot of cases where the things that you're anticipating to find won't be there, but you still need to look. Number 7 says differential in pulses 30% of the time, 30% of the time. Although unfortunately, a lot of these cases are, when you look at the papers, they are retrospective chart reviews, which means that the doctor has to put down that they looked, they have to put down that they found it, kind of thing. And so chart reviews by their nature are really pretty problematic in these cases. 8 and 9 are a summary of a bunch of cases. There's a little misnumbering in there. I think their number was repeated twice. I think it was 7 was done twice. But anyway, so here's a bunch of cases. 464 cases in number 8, 236 in number 7. Mean age, relatively young. In number 8, it was 63. So we see 61, 58, 63. So it's all around the same, around 60 years old. But they all talk about this huge age range. They talk about 17-year-old kid having a dissection up to age 94. There's a moderate male predominance. What about this idea about hypertension? 3/4 of the people have hypertension, so that means a quarter doesn't. Severe pain, most of the cases. Well, one paper said 90%, the other paper said 75%. So we're talking about it is in the majority, but certainly not all, and I think that that's one of the take-home messages here. Syncope was not uncommon, 9% of the cases. What other of the big 3 is associated with syncope? The big 3 diagnoses, sometimes people faint when the association with it is PE. So PE is one of the, when you have a PE big enough to cause you to faint, it's not a very subtle kind of thing. You've blocked off a huge amount of blood going into your lungs. That's not going to be this little clot way out the periphery. But the idea here is these overlapping circles, which can confuse you about what the real diagnosis is. Abnormal chest X-ray, 80%. The papers say about 65, 75, 80% will have an abnormal chest X-ray in terms of some widening of the mediastinum, and we'll talk about a paper that more specifically about that in a bit. Pulse deficits were very uncommon in these 2 reviews. So sure, put it down that you looked. Don't count on it, though. Imaging, how good are plain X-rays? Everybody's going to take a plain X-ray in these cases. That's number 11. Sensitivity plain X-ray, 65%, which is on the lower side. Most of these papers are higher in terms of what you can expect. 80% is certainly better than the stuff about the pulses being unequal. Basically, they talk about you're just gestalt for saying, yeah, there's something wrong with that mediastinum kind of thing. When they point out which is the X-rays, which of the dissections going to be more likely to have an abnormal chest X-ray, it's not the type A's where they come off the root of the aorta and go up to the top. It's the ones that begin on the top and go down. And that makes some sense, because if you're going to go down the aorta kind of thing, then you're looking for, it's not just going to be the arch, it's going to be the whole thing is going to get wider, your mediastinum will be wider. But basically, it's about 80%, and number 11 and 12 talk about that. They talk about some inter-rater variability in terms of picking this finding up, and they said that's an issue. And even the number 12 is talking about radiologists are inconsistent in their ability to pick this up. And then there's the CTA business. We have a talk on CTAs, actually the triple scans. Any of you doing these triple scan things at your hospital? You got it. Well, basically to do these, you have to have a 64 or faster CT, right? Is your 64, Peter?
Yeah, we have a 320 as well.
You have a 320?
We're getting one, but we have 64 right now.
So 64 is about coronary arteries. That's really what it's about. Coronary, it's about taking a picture so fast that it's in time with your coronary arteries. I mean, your heartbeat, it's like it's gated, so it's taking the picture of the part of the cardiac cycle that it wants to and doesn't have to take it where it's not, kind of thing. And there's some paper, I don't want to take away from that triple scan discussion, but there is a paper that we're doing in the abstracts, and we're recording it this coming Sunday. And it basically said, okay, you've got a 64 scan machine now, You shoot in the dye, and you're looking for three things. You're looking for the coronary arteries, you're looking for the pulmonary circulation, and looking for the aorta. But the fact of the matter is that if you shoot for the coronary arteries, which is kind of like statistically the thing that you're most interested in, you're not going to have a great picture necessarily of the other two kinds of things. So everybody's now trying to develop a strategy for doing these so that you can get the best picture of the coronary arteries, pulmonary circulation, and the aorta. And this paper basically said that we're going to do, well, if you shoot for the coronary arteries, you're going to have a great picture of the coronary arteries. But what about the other two pictures that you're looking for? They said your picture of the aorta is going to be really pretty good as well. But your picture of the lungs for pulmonary embolism is not going to be diagnostically acceptable. So they're going to be wrestling with this because there's going to be more and more hospitals getting 64s and fasters because they want to basically look at coronary arteries rather than doing these invasive tests. So there's only one of you in the room now who has a 64. Is that correct? Oh, you have anybody who has 64s? Wow, that's a different story. So 64s, anybody doing these triple scans on anybody? What kind of luck have you had? No luck.
And I don't know whether or not that's reader dependent.
It's reader dependent. Well, they basically said that you got to set the kind of looking for, what are you looking for? We're looking mostly for coronary arteries, and these other two kind of things are kind of a problem. So they said we don't have the technology down yet in terms of getting this resolved so that all three areas are diagnostically to the level that we think they need to be. What's the role of the Ddimer in looking for in assessing these cases? You got this dissection of the aorta, generating this big clot between the layers of the aorta kind of thing, maybe some free bleeding as well. Some people say if your D-dimer is negative, you don't have an aortic dissection. But in medicine, we never say never kind of thing. But the numbers are kind of interesting here. 15 and 16 talk about this. And the long and short of it is that 95% of aortic dissection should have a very positive D-dimer. And depending on what cutoff you use, some of these studies say 100%, but you certainly wouldn't take that to the bank. But 95% would have a positive D-dimer. And then, so the negative predictive value, if you don't have a positive D-dimer, your chances are pretty small that it's a dissection. Now, there are a couple of papers that somehow got avoided in this chapter that I wrote. And so those of you who are subscribers to the abstracts, there are a couple of other papers. There was one that was done in May of 2008 that we did, abstract number 11. It was in European Heart Journal. It was a review of 16 studies, 437 patients, found a pooled sensitivity of the D-dimer, 97%. Pooled sensitivity, 97%. 97% of the time, it will be positive in that diagnosis. Now, there is this issue of confidence intervals. 97%, we're talking about 437 cases, so that's a lot of cases. So the confidence interval should be relatively narrow. It turned out that the negative predictive value, 92 to 100%. So there is this range. And then another one that was not in the manual said the sensitivity for a D-dimer was 94%. So the numbers are around 95%. So it may be part of your strategy in terms of these cases to do that, because if it's negative, it's not likely to be, although never say never. Current treatment, they haven't changed the treatment of this stuff hardly at all. Still about beta blockers to decrease this pulsatile force that is dissecting this aorta and lowering the blood pressure. And so the only thing they talk about is, well, which beta blocker are you going to use kind of thing. Esmolol is fast and has a short duration of action, so it's kind of more titratable. Labetalol is a lower your blood pressure because of its alpha antagonist effects, plus it's a beta blocker too, so that might be a nice choice. And they talk about propranolol, which is, nobody uses propranolol much anymore. It has a real long half-life, so if you overshoot, you're kind of going to have a bit of a problem. And then talk about nitroprusside, titratable for getting your pressure down. That's the only thing you can do is make that diagnosis, give them a beta blocker to piss them in terms of their this contractile element, lower the blood pressure, and that's your job is done. You've made the phone calls. The last paper here talks about litigation regarding aortic dissection, and it was written by some cardiothoracic surgeons who say, you know, we have an opportunity to review a lot of these cases. They're from Yale, and they kind of said, if you don't think the diagnosis, you'll never make the diagnosis. It often tends to be a needle in the haystack. If they're talking about, you need to be really, really cognizant of the fact that you could not have some of the things that you're expecting. The classic findings are often in the minority, and you have to be willing to accept that young people can have this diagnosis. Textbook typical findings are often absent. Ddimer, a negative Ddimer would be very uncommon, is what they said. Other people have said a negative Ddimer would be rare in these cases. And they basically ask for doctors to be liberal with their imaging. But the imaging they're talking about is not a chest X-ray. The imaging they're talking about is CTAs. Yes, but they're looking at it from this perspective of these are missed cases, these are litigated cases, and in litigated cases, somebody made a mistake kind of thing. So it's natural to kind of assume that in that environment, you're basically going to tell people to kind of look more carefully, look more aggressively kind of things. But we cannot be doing CTAs in all of these people looking for this diagnosis. In terms of the radiation is going to be substantial, and the likelihood of the diagnosis is going to be small. So you have to put that into perspective. These guys are looking at cases that were litigated. So I think that's basically the sum of what we have in our database on this entity. Keep your fingers crossed that you're not working when the next one comes in. That's basically, pass it on to your next doctor. You know, there's a person in there wearing a stovepipe hat that's got a beard, that's got some back pain. I'm going to let you pick up that case. Thank you very much.